Welcome to This Explainer. You know, today we're moving way past the standard conversations about cholesterol and blocked arteries. Instead, we're diving into the fascinating, unexpected, and frankly astonishing ways the human heart can be attacked from the outside in. I mean, we constantly hear about clogged pipes and lifestyle choices, right? But have you ever actually stopped to wonder, can the heart itself get cancer? Or what happens when your own immune system decides your heart is the enemy and just declares all-out war on it? The pathology of the heart is honestly far more bizarre than most people realize. So here's our roadmap for today. First, we'll look at systemic and pericardial diseases. Then we'll cover primary tumors, followed by outside cancers. And finally, we'll wrap up with heart transplants. All right, let's jump right into Section 1, Systemic and Pericardial Diseases, or as I like to call it, attacking the armor. So the pericardium is supposed to be this flexible, protective sac encasing the heart. But when systemic inflammatory conditions like severe rheumatoid arthritis involve the heart, they can cause fibrinous pericarditis. This inflammation leads to fibrous thickening and these dense adhesions that literally obliterate the empty space around the heart. It essentially turns your flexible, life-saving armor into a rigid, dangerous trap. And in extreme cases of constrictive pericarditis, this fibrous scar can actually resemble a literal plaster mold or concretio cordis. Just think about that imagery for a second. The heart becomes encased in a dense, fibrocalcific scar that can be up to a centimeter thick. Because of this rigid enclosure, the heart physically cannot expand to fill with blood. It severely restricts cardiac output, meaning your heart has almost no capacity to pump harder when your body really needs it to. Moving right along to Section 2, primary tumors, which are rare but very real. Now, primary cardiac tumors, meaning tumors that actually originate directly from the heart tissue itself, are exceedingly rare. We're talking about them occurring in only about 5% of people dying of cancer. They are vastly outnumbered by metastatic tumors, which of course are cancers that start in other organs like the lungs or breast and then spread to the heart. What's really fascinating here is that when a primary tumor does actually form, 80 to 90% of them are entirely benign. Only about 10 to 15% are malignant. So a primary originating cancer of the heart is just incredibly rare. But hey, benign definitely does not mean harmless. The most common primary tumor in adult hearts is something called a myxoma. And because of exactly where they grow and how they move, myxomas can act like a literal wrecking ball inside the heart's chambers, causing some pretty devastating mechanical destruction. An atrial myxoma is basically this large gelatinous mass that typically hangs from a little stalk in the atrium. Because it's highly mobile, with every single heartbeat, this mass can actually swing right down into the mitral valve orifice. It creates this ball valve obstruction, intermittently blocking blood flow entirely. And worse, because the tissue is soft, pieces of it can actually break off and shoot through the bloodstream, creating a dangerous embolization that can wreak havoc elsewhere in the body. Aside from myxomas, there are a few other bizarre primary tumors that can pop up. Papillary fibroelastomas, for instance, are these really curious sea anemone-like growths typically found right on the valves. Then you have rhabdomyomas, which are actually the most frequent primary tumor in children. They're often linked to tuberous sclerosis and famously contain these bizarre stretched-out spider cells. Finally, lipomas are localized fat cell deposits that can occur right in the heart muscle, sometimes causing what's known as lipomatous hypertrophy. Okay, let's pivot to Section 3, when outside cancers attack, the invaders. As we noted earlier, metastatic tumors are the true frequent cancer threat to the heart. The most common culprits here are lung carcinoma, breast carcinoma, melanoma, leukemia, and lymphoma. These invaders typically arrive completely silently. They can reach the heart by traveling backward through the lymphatic system, spreading via the bloodstream, or even just by direct physical extension from a neighboring organ. And this brings us to a truly terrifying mechanism of invasion. Kidney cancer, or renal cell carcinoma, can physically grow like a solid advancing snake, pushing its way all the way up the inferior vena cava, which is one of your body's largest veins, and directly into the right atrium of the heart. It completely blocks blood from returning to the heart. It's just a striking and devastating example of tumor extension. So outside cancers essentially wage war on the cardiovascular system across three distinct fronts. First, you have the direct physical consequences, like those metastases and vessel obstructions we just talked about. Second is indirect chemical warfare. Tumors can release circulating mediators that cause secondary heart diseases. And third, There's the terrible irony of tumor therapy. The very chemotherapy and radiation used to save the patient can actually induce severe cardiovascular side effects, including myocardial fibrosis and accelerated coronary artery disease. Finally, we arrive at Section 4, heart transplants and their hurdles. Human-to-human heart transplants went from an impossible dream before 1967 to a clinical reality with over a 90% one-year survival rate today. This absolute medical miracle really relies on three major keys. 1, the development of highly effective immunosuppressive therapies like cyclosporin A. 2, the incredibly careful selection of transplant candidates. And 3, the ability to achieve early microscopic diagnosis of acute rejection via biopsy. But here is the ultimate tragic irony of transplantation. The very immune system designed by nature to protect your body instantly recognizes this life-saving new heart as a foreign invader. And without those powerful immunosuppressive drugs we just mentioned, your body will relentlessly and aggressively attack its new life-saving organ. Microscopically, it's a literal battlefield in there. With cellular rejection, the immune system's lymphocytes actively infiltrate the heart tissue and cause immense damage. Then there's allograft arteriopathy. This is a late progressive issue where chronic immune reactions cause severe intimal thickening. Basically, your own immune system is dangerously clogging the new heart's coronary arteries over time. And that leads to a pretty chilling reality. Transplanted hearts pose a silent threat when things go wrong. Because the new heart's nerve connections are completely severed during the transplant surgery, the heart is considered denervated. This means patients literally do not experience angina, that classic chest pain we all rely on as a vital warning sign. If that allograft arteriopathy causes a heart attack, the patient won't even feel it happening. Which leaves us with this profound final thought. As we conquer the incredible physical and surgical mechanics of swapping a human heart, will our own protective biology, our own immune system, forever remain the final, most dangerous hurdle to a perfect cure? It's really something to think about as you consider the